Well, that's woken everybody up after lunch. Good afternoon. Welcome back to the conference. I hope you all enjoyed your lunch. This afternoon's session is boldly entitled What Works? And I think for a lot of us that's the million-dollar question, so I'm really looking forward to hearing from our speakers. Before I go on to that, I've got some announcements to make. The first one is about phones. If you're sitting on the platform, please turn your phones off. If you're not, can you put them on silent? Because you'll obviously be wanting to tweet and the hashtag you've got in your programme, and it's up on the screen there for you. I'd like to welcome our viewers who have joined us on the web, and there are viewers watching from satellites in Glasgow and Edinburgh, as well as individual viewers watching from around the country, so welcome to the conference to those people. We're filming an audio recording the conference, and presentations, footage and podcasts will be available for you free of charge after 12 noon tomorrow. If you haven't noticed them, in your pack there's 2 sheets of light blue paper, and that's the evaluation form. And could I please encourage people to fill them in and let us have the feedback. It's really useful in making sure that the conference is even better next year. Pathway and the faculty are very pleased to have the support of the Health Foundation, Homeless Link and Crisis for this event. I'm pleased that representatives from those organisations have joined us here. Seminar sessions. If you haven't signed up for your seminar sessions, could you do so in the catering area immediately after this session? We will be going on, and for those of you who have looked at the programme and have noted that there's a burning issue that you would like to discuss that hasn't been included, there is an opportunity. Tomorrow lunchtime, we're gathering in here to form discussion groups on your chosen hot topics. So we'd like you to volunteer a suggestion for a discussion and to host a table here in the auditorium. It will be fairly formal, and we just want to take the opportunity of bringing like-minded people from different parts of the country to share experiences and to discuss the topics that are of interest to them that aren't covered elsewhere on the agenda. And I hope lots of you take up that offer. If you have a topic which you would like to facilitate, could you see Helen Davis, who's on the reception desk, and let her know, and then we'll organise the tables and the discussions for tomorrow. So I think it's a great idea to do this at a conference, and a really good opportunity to bring people to get together to discuss the issues, burning issues for them. So thank you for that. I'd now like to go on to introduce our speakers for this afternoon. Our first speaker, I'm sure many of you know, Nigel Hewett, who's the Medical Director from Pathway. Nigel will be followed by Viv Askaland, who is one of our experts of experience. I'm sure many of you would have met Viv either this morning or at the last 2 conferences that she has attended. To my left is David Pryor, who is Chairman of the Care Quality Commission. And on my far left is Professor Kevin Fenton, the Director of Health and Wellbeing from Public Health England. I hope we get lots of time for questions, and I hope as the speakers are speaking, you're jotting down notes with questions to ask, and we'll have time for those when the speakers have finished. So if I'd like to ask Nigel to start us off. Thank you.
It's always a relief when your slides come up when you press the first button. So thank you very much for that introduction. My plan is to spend the next 15 or 20 minutes just really bringing us all up to the same page with the development over the last 5 or 6 years of the faculty, the story of Pathway, and with some apologies to those of you who've been intimately involved with this development over those years. But we're then going to be particularly focusing on the last year and our vision for the future and where we hope we can take the faculty. So my personal experience of working in homeless healthcare, like many of you, is quite a long one now. In fact, it's almost exactly 25 years ago that I first started providing an outreach clinic at a drop-in centre in Leicester, the Medicare drop-in centre. And this was just a half-day clinic on an outreach basis, just me in the drop-in centre. But over the ensuing years, the service grew around me. We became a PMS pilot in 2000, and by 2007, 2008, we'd moved into the Dawn Centre, an architect-designed, purpose-built set of premises which combined a health centre with a full range of healthcare facilities, with a voluntary sector-run drop-in centre and a hostel run by the local authority, 42 beds, all en suite, built-in dog kennels on the ground floor. And it was the living embodiment of the close multidisciplinary working which we developed over the years in Leicester. And when I kind of look back over that period and try to understand how we managed that, what was it that we achieved, I came across this quote from David Ogilvy, who's the father of advertising from the last century. And he suggested that the key to success was to recruit people who are better than you are, then step back and take the credit. And actually, I think that's pretty well been my plan over the last few years when I look back. And it sounds a bit manipulative and Machiavellian, but when you consider the alternative, it is to do the opposite, step up and take the blame, and that's definitely worse. So on the theme of recruiting people who are better than you are, although it's been 5 years since I had any involvement with the Leicester service, as you were hearing from Aidan earlier today, this is now a service which is an independent social enterprise, a community interest company, has another new building in Charlesbury House, and is one of the few practices in the country to have achieved an outstanding accreditation from the CQC. So although many of us have the feeling that we are rather swimming against the tide, it is possible to do excellent work in this field. I've also been thinking a little bit about the term inclusion health. Now, inclusion health, I think, came out of the social exclusion unit. So the idea was, well, if the healthcare system is to have a response to social exclusion, it'll be about including people in. And it allows us to encompass other groups like gypsies and travellers, sex workers and vulnerable migrants, as well as homeless people. But it's not a very sexy term, really, if you're trying to inspire medical students and nursing students and young physiotherapists and OTs to get involved in this area. I've wondered about extreme medicine, it's kind of got a hang glidery feel about it, or possibly marginal medicine. But I think the key thing is that we're outliers. I think we're all of us individually, professionally outliers, and the people that we're working with are outliers, out there on the edges, on the margins of society, trying to help people who are characterised by complexity, by multimorbidity, which really just means lots of different conditions which interact together. In fact, Al Story, who was talking earlier today, taught me a new word this year, which is syndemic, and that's worth just Googling syndemic. It suggests that all of these conditions, in a kind of synergistic way, work together to make things worse for people. But one of the good things about the work that we do is that and perhaps the most useful thing that we do, is to stand alongside our patients, the people that we work with. And that can be very scary, but also very exhilarating when you're standing alongside somebody who's got nothing left to lose. But I also think there's nothing more powerful than a person who's got nothing left to lose. And I'm sure that you, like I, have drawn a lot of strength over the years from the courage of those of you in the room now who really know what it's like to have nothing left to lose, but still find the courage to stand up and look the world in the eye. So perhaps a good way of looking at being out on the margins is that we're surfing the breaking edge of chaos. We're out there where it's exciting, where things are constantly changing, where you have to adapt to survive. I think this is quite a nice analogy. I have two opposing pictures in my head when I'm thinking about surfing the breaking edge of chaos. One is that aftershave advert where the lithe, muscular young man is balancing perfectly down a tube of a wave. The other image on bad days is the last scene from A Perfect Storm, when a massive wave is about to come crashing down on the little fishing boat and obliterate everybody that's in there. But this is the creative space that we've chosen to work with. So mixing my metaphors with huge abandon, the wave comes crashing down onto my hotbed of innovation, and there's lots of new and exciting things happen out there in this world. Primary care-based drug and alcohol treatment, innovative community-based Hep C treatment, approaches to personality disorder, and the very idea of outreach care, taking healthcare to where our patients are, into hostels, drop-in centres, and out onto the streets. The embracing of multidisciplinary care, of working closely alongside people from a wide range of disciplines, and the approach of reflective practice, which increasingly we're adopting in the many different areas in which we work to improve the quality of the care which we can offer people. And of course, through all of this, the thing which we're trying to live out through this conference is the involvement of experts by experience, people with a lived experience in planning our services, in training the people delivering those services, and actually in-service delivery. So all of these innovations are things which have come out from that breaking edge of chaos. But there are disadvantages to working out on the margins as well. Our services often get tarred with the same brush as our patients. We all know about the negative stereotyping of the patient groups that we work with, and there's often an assumption that we're kind of a crackpot group providing a second-rate service for people who don't really matter. I think that can be reflected in the buildings in which we work. For many years, I did a weekly clinic in a hostel, literally out of the broom cupboard, and so many homeless services that I go to visit are still in windowless basements. So I think our services get pushed out to the margins. And our services are often cost outliers. The per capita costs of the services appear high. You get gaming of budgets, refusal to accept people from our client groups as patients because they look expensive. And even when we know we're providing really cost-effective services which are improving care, the challenge of crystallising those savings, responding to the show me the money question is very difficult for us. We're often prescribing outliers. Many of you remember Harold Shipman, the infamous GP who murdered hundreds of his patients. And shortly after that, the Professor Baker from Leicester was looking at ways of trying to identify potentially the next shipment. And one way of doing that was to analyse prescribing patterns across large geographical areas. And he came to speak to a group of us in Leicester, and he had an anonymised graph of all the GPs in Leicestershire with their per capita prescribing of opiates compared to the patient population. Remind you that methadone is also an opiate. And this graph trundled along with nobody really standing out, apart from one massive spike down the far end of this graph. And I knew that was me. So I put my hand up and said, I think that is me. But I'd been anticipating this moment, and I was able to send him quickly our methadone protocols, the audits of our compliance with those protocols, and our outcomes, and be able to prove to him that our primary care-based service was getting better outcomes than the local specialist drug treatment service. But as we've heard from many other people in the room, the weariness of never being mainstream, endless short-term funding, pilots, initiatives, never really being embraced by the mainstream, and not really having any NHS voice, and that does rather drag you down. We didn't have much of a classical education at my comprehensive, but I read subsequently about this Sisyphus chap who was doomed by the gods to endlessly carry a rock up a mountain. It would keep rolling back down and crushing him. He has to keep getting back up and pushing the same rock back up the mountain. And it has felt a bit like that over the years. And again, I'm sure many of you have felt to be in the same situation. And I've often wished for a fairy godmother that could come along and magically turn this rock into a carriage that would whisk me off into the future. And at times even I'd have settled for a fairy godfather, which was the point at which Aidan Halligan came crashing into my life and invited me down to University College Hospital along with Trudy Boyce, a nurse colleague who is really actually the person who's made all of this happened. Trudy is somebody with infinite patience and compassion, much nicer person than I am, and really, if she hadn't been there, none of this could have happened. And you can learn from the Pathway stream of workshops the whole story. But 5 years after we first arrived in the hospital, we were finally embraced by the hospital, the chair of UCLH coming on the ward round, and this illustrates that the core Pathway service, a nurse specialist in the hospital, somebody ideally from a service user background. There's Josie, our care navigator, and GP-led ward rounds and weekly multi-agency meetings in which we all get together across the statutory sector, the voluntary sector, community and hospital to do care coordination for the most challenging patients that we're dealing with. So this approach has won a number of awards, and there are now teams around the country, each one of them adapting to their local situation, and all of them different, but we now have 10 hospital trusts around the country from Bradford to Brighton with Pathway teams. One of the arguments which we've had to look at is how we justify what we're doing, how we can provide arguments to make this seem like a good idea to commissioners. And the idea of do our values add value? And in this we were helped by Professor Michael Porter of the Harvard Business School, who provided a masterclass for UCL partners in 2010 when he used the Pathway approach as an example of his values-based commissioning. And the idea that value means outcomes that matter to patients expressed in terms of the cost of the whole care cycle, which is a slightly complicated way of saying, rather than looking at process, if you look at outcomes and what it costs you to get that outcome, you can get much better value for the money that you're investing. So that rather than have the same patients come to A&E every couple of weeks and feeling pleased that you get them out in 4 hours every time, you might get better value from those 25 interactions in the year by actually finding out what that person wants, what outcome they're looking for, and trying to work with them to get them to a better place. So the other part of the narrative is the charity which Aidan set up, the Pathway charity, to try and improve healthcare for homeless people. Again, built around the core values of service user as the centre of this, and again, Josie Mavromatis, our first care navigator, led by Aidan Halligan and supported by an eminent and a very active group of trustees who've shepherded this along over the last 5 years. And one of the things which Pathway, the charity, has done has been to support and help set up the Faculty for Homeless and Inclusion Health. And you won't be able to read this slide, but this is the minutes from one of the early meetings in early 2011. And it just reminds me of the wide range of people involved in those meetings. Hospital and community doctors, nurses, mental health nurses, psychologists, psychiatrists, psychotherapists, lots of people with a lived experience, researchers, commissioners, all getting together because we're interested in healthcare for homeless people. And one of the first things which Aidan challenged us to do was to write a set of standards for healthcare for homeless people. I was rather nervous about this. I mean, nobody had asked us to do this. Nobody had even given us permission. But we kind of thought, well, who better than us in the front line, working alongside service users, to say what good looks like. So we wrote the first version of the standards, and we put it out there on the internet. And within weeks, we were finding, going to meetings with commissioners, they were holding copies of the standards. So that seemed like quite a good thing. Within a couple of years, the National Inclusion Health Board had helped us to become legitimate. They'd given us some funding to provide a second edition of the standards to reflect the 2012 Health and Social Care Act, and to provide details of what good looks like in a variety of different healthcare settings and responding to a variety of different excluded groups. And these standards are available to download from the Pathway website, and this is something we'll continue to develop and improve. The faculty holds these conferences. Our first conference in 2013, Anna Soubry announced the DH 10 million Hospital Homeless Discharge Fund. Our next conference in 2014 was even more about the service users and centred around the service users, responding to feedback from the first conference. But we still had an eminent group of speakers to encourage and inspire us. And we also launched the second version of the standards, was launched at this conference. And in one of the workshops here in these breakout rooms, we discussed how we can demonstrate that we are meeting the standards. The faculty had gone on meeting over these years. We meet 2 or 3 times a year in London, and we now have regional meetings in the north, the east, the south, the Thames Valley, and there also is a mental health subgroup, the Faculty Interact, which has spun out of all of this enthusiasm. And at that conference workshop, we decided that we wanted a process of peer appraisal which would allow us to identify good practice and encourage us in our work. We didn't want to replicate what the CQC does or monitor or Health Watch or revalidation or any of these other processes, but we did feel that commissioners particularly might not see what additional value they were getting from the high quality healthcare that we were providing because we are outliers. So we've come up with a process in which services can be graded as committed, achieving or excelling across this range of values. And again, there's a workshop tomorrow, workshop C4, which will give you a lot more detail about this. But after piloting this process between the York Street practice in Leeds and the Brevin practice in Bradford, we've mapped the standards across all of these national standard frameworks. And the core approach here is a self-assessment questionnaire which any service can use as a quality improvement process, and then a visit with 3 core members of the visit: a clinician from another similar practice, a service user representative, and somebody from the faculty. So we piloted this with a nurse or a GP from either of those 2 practices, Stan, our service user representative, and myself for the pilot. And we would like now to roll this out. We've started with primary care services because the feeling was that's where the most enthusiasm for this approach was. But we think that this peer appraisal, peer validation is a model which is used by liaison psychiatric services, for example, the Psychiatric Liaison Accreditation Network, and we could roll this out across other services, podiatry, dentistry, community mental health services, whatever you wanted. We could work together to identify what good looks like for our services. So where are we going next? Well, really the point of the faculty, the reason we're all here is about uniting around the people that we aim to serve. I think perhaps the key concept, the one thing we all have in common, the way that we're all working, is individual care coordination supported by a multi-agency team. Meeting that individual where they are, starting with their agenda, with the thing they want fixing first, and then going on from there to build around them the support that they need to move towards better health. It's all about non-hierarchical, interprofessional working as a team with nobody top dog. We're developing interprofessional training. Again, there's a workshop on this. We've had some CPD days led by members of the faculty, and we'd like to work towards a point at which we have a national network of training with ultimately a master's qualification in inclusion health or extreme medicine, possibly. We're working to develop to further constitute this faculty which we've formed together and further enhance our links to the Royal College of Physicians, which have invited us to have a memorandum of understanding and work more closely with them. We need to continue to gather data and publish, and really our ultimate goal is to transform the NHS from the inside out. So thank you very much.
Thank you very much.